Good morning, everybody. I'm very happy to be here. I'm looking around the room and to see a black man, to see a black man, and it's inspiring to me because you're here to talk about your health, you're health conscious, and I didn't really grow up seeing anything like this. So I hope you're passing this on to your sons, your grandsons, of course. I'm happy to be here. Thanks, Dr. Parker, for allowing me to be here, share with you Alzheimer's Institute at Emory. I'm Dr. Isaiah Rolle. I'm a stroke neurologist. I work at Emory University Hospital. I also work at Great Memorial Hospital. I am in the hospital 100% of the time, which means that I'm not in a clinic right now. So I can't see you directly in the clinic setting because I'm always in the hospital. But that's kind of what I specifically do. And so I kind of want to talk today just about the impact of stroke on memory loss, what I sort of titled Forgetting to Remember. And so this first part is called Get Harry Home. Okay. Harry is a Marine. He had served in the tail end of the Korean War, and he's my grandfather. Okay. Harry had a really big personality, had a really big laugh, and he told stories all the time. There was a point when I was really young where we lived with him, and he was telling me stories all the time, right? Like in bed at about 7 years old, he's telling me stories that are a little graphic for a 7-year-old, if you will. But he's telling stories, and he's telling me stories about war. One point he was overseas in combat. Now I'm 7, he's telling me stories about war before bedtime, but that's a different topic for the day. And he tells me about being in combat, you can imagine. One point he was in combat, he couldn't use his gun because he ran out of ammunition. And so he thought what he was going to do next. Now, at that time, my grandfather was sort of a makeshift handyman. He carried a tool belt all the time, but he always had this knife. There's a knife that had a pretty big handle, and the blade was probably about 7-8 inches long. He would chop his tomato, he would chop cucumber, he would carry this knife. And so during this story he's telling me, he pulls this knife out. And then he says that at this point, when he lost ammunition, he named his knife Get Harry Home. And as you can imagine, in combat, it got Harry home. And he had it, and he got all the way home, and he had that knife in his hand, which he's showing me. I tell that story because I never forget it. There's so many stories that my grandfather told me that I remember. And as we got older, as I got older in some years, spent time with him, he developed probably a combination of different neurologic disorders. He wasn't the same man, he wasn't the same smile, the same expression, his movement was off, couldn't think as well as he could. And I thought to myself, I'm going to cure my grandfather's ailment. That's what I wanted to do. And a few months just before I started my first day of medical school, he died. And I thought, man, I'm not going to be able to save him. Now, it's obviously a lofty goal to think that I was going to actually cure his disease. I like to think that as I speak to people, speak to patients, share about stroke, share about dementia, it's all a part of the process to get Harry home. And so that's what we're going to do today. We're going to go to get Harry home. And so we talked a little bit about dementia today. You will understand right now that dementia is the big term that just sort of says that this is a set of disorders, set of brain diseases that all affect our memory, our personality, who we are. But underneath that umbrella are a bunch of different names. There's Alzheimer's, old-timers, you all know that name. That's the big one. What we're talking about today is vascular. That's the one that comes in number 2. You see this chart right here, this Alzheimer's takes the big share. That's the orange section. So it's a lot of people who have dementia. Most of their names in the call is going to be Alzheimer's. But coming in actually at number 2 is vascular. It's about up to 20% of people who have dementia have it vascular. And then beyond that, there's probably some mix, some kind of combination of Alzheimer's, combination of vascular, and so on and so forth. And so what is vascular dementia? Well, in the name, for me, it's simple. It's vascular and it's dementia. Vascular means any blood vessel in your entire body. That's a blood vessel, that's vascular. But in my world, I care mostly about the blood vessels that lead to your brain. So we're talking about in your neck, and in your head, the blood that goes to supply your brain, that's the one that I specifically talk about when I'm talking about vascular dementia. And so that's blood flow to the brain. And dementia is difficulty in your memory, concentration, your personality, communicating, learning information. So putting that together, we're talking about vascular dementia. And this is long-term, poor blood flow to the brain that's usually developed by a series of strokes or stroke-like changes that are happening in the brain. And so I would be remiss that the stroke talk about stroke for a second. So the first part of stroke is that it's not something that comes on like I had a headache for a couple of days, I just kind of feeling ill. No, stroke happens at the stroke of midnight. It's something that comes without warning in most cases. And so we talk about be fast. B is for balance. You all of a sudden just lose your balance. You're not really weak on your leg, your arm. You just lose your balance. That's the problem. E is for eyes. If you lose vision, one or both eyes all of a sudden. The F is for face. When your face might droop or be uneven on one side or the other. A is for arm, or it could be leg that becomes weak on one side or the other right away. S is for speech. The speech can either be slurred, where it's kind of difficult to hear exactly what you're saying, kind of like that. Or the word that you want to say, you're saying a completely different word. So you mean to say apple, but what actually comes out is chair as a speech problem. And then T is for time. Call 911 right away. Any of these things happen. Those are very easy, obvious things that we can all see ourselves. Let's get to treatment right away. That's what we want to do. And so these are some pictures of CT scan. It's a CAT scans of the brain. This first one here is normal. You got kind of the bone around the edges. The inside is gray, that's the brain. There's a little bit of black stuff in the middle. That's just the normal fluid-filled spaces. Move over a little bit to the ischemic stroke. That's the kind of stroke that we're talking about here. Like you lose blood supply, you lose oxygen to that part of the brain. It's that really dark area there. That's a stroke that someone's having. And then next to it is the hemorrhage or bleeding kind of stroke. Someone had a brain bleed or intracranial hemorrhage. And so if someone has a symptom like that be fast symptom right now, I can't tell the difference between the ischemic stroke or the bleeding stroke without getting this scan. It could be either or, because either of them will cause the same set of symptoms. And then beyond that is the subarachnoid hemorrhage. That's kind of, people have a little bit of blood in the larynx, the lower areas of the brain, usually by an aneurysm. So this is kind of what it looks like. Now we're going to talk a little bit about causes. There's about three top causes of stroke that we're going to discuss. And I want to see how we can kind of relate that back to our dementia. So this first one is called large blood vessel disease. Okay, as you can see this picture here, this is kind of comes from having cholesterol plaque build up in those blood vessels. Okay, a cholesterol plaque that builds up, it's mostly driven by the one that's called LDL. That's a component of your cholesterol. You lab your cholesterol to PCP, you get the labs. It does not just say cholesterol only. It'll have cholesterol, it'll have LDL, HDL, and triglyceride. So the LDL is the main one that drives that bad cholesterol that builds up the blood vessels. So if you can imagine, if you have that plaque building up, it's just going to block the blood flow, basically. But not only that, but that sort of plaque itself is like hard crystal-like structure that can break apart, and that can kind of cause issues going down the blood vessels. Or imagine if your blood is passing by that sort of cholesterol plaque, the blood vessels can then break apart and cause a small blood clot to go beyond that. Or if you just have so much plaque that's just blocking the entire thing, the blood just will not get through that entire blockage. So if you imagine the blood vessels in your neck and in your head to be like a tree, a big tree, a tree trunk that has branches, if you imagine that you have a blocked blood vessel, it's one of the very high branches of a tree, you're only going to get damage in the leaves that are just in that one section. But if you have a blockage of the really big base of the tree, the one entire trunk, you're going to have damage to the entire tree. That's kind of how the blood vessels are in the neck and the head. So the large blood vessels are mostly affected by this plaque buildup in the body. And I would just say this, that if you have plaque anywhere in your body, it's probably going to be everywhere in your body. You don't just build plaque. just in the heart. If it's in the heart, it's probably in the vessels in the brain too. Okay, it's an entire body situation. The second type, or the cause of stroke, is small blood vessel disease. This is driven mostly by, you named it, long-standing, uncontrolled high blood pressure. So this is the biggest driver causing these changes. Folks who have this happening, their blood vessels over time are just getting small, slowly damaged, step by step, without you even noticing it. You don't get symptoms from this all the time. In fact, most people really don't. And so you're just getting changes happening to those blood vessels all the time. There's something that I made. I moved to Atlanta, that's what I was going to say right here. I moved here in 2019. And when I got down here a couple of years of practicing, I named something myself called the Georgia Special. This is when, in my mind, the folks have high blood pressure, diabetes, kidney disease, high cholesterol, obesity, and smoking. Wow. Like, that's it sounds like a lot, but in my world, like a lot of patients have all of those all the time. That's a classic patient who ends up having this small blood vessel disease. And so uncontrolled high blood pressure over time being the biggest driver to that causes these small changes in the brain. The third and final one is your heart. Heart conditions, or we call it cardiac or cardioembolism, is the biggest other driver for stroke. This one we mainly talk about is AFib. And you've probably heard that term before. It's called atrial fibrillation. It's a rhythm problem in the heart, and it can form blood clots to form strokes. And so AFib is diagnosed by like an EKG or a heart monitor. You may have sometimes people have an implantable monitor around the heart, or even like an ICD, or sometimes even your Apple Watch or smartwatch might actually detect parts of it. This is the way that we know that you have AFib because you don't always actually feel it. And so what is AFib actually? Well, this is a typical heart. Typical heart has electrical rhythms that send down the entire heart to make it pump. Your heart should be pumping on rhythm, on time, on target every single time. And your blood is flowing through as it pumps. So you put that song on, and it's the same exact beats per minute every single time. But AFib is when that becomes erratic. That electrical signal now sends it in the wrong direction. And now you've got like 3 or 4 different tracks or records at the same time playing. And now it's some fast, some slow, some pause for a few seconds and just, take a nap and then come back in. And now you have chaos. And the blood that's trying to get through that heart is also having chaos. And that forms a blood clot that shoots up the neck and into the brain and causes a stroke. And so that's kind of what AFib actually is. And so give you a little data here. I looked at atrial fibrillation and that connection to dementia. And so the first part of it is that AFib alone increases someone's risk for stroke by about 5 times. And so for me as a neurologist, when we see AFib, it's a no-brainer. We treat it right away. It's like if you had a stroke or you even possibly might have one, we treat that with blood thinners right away. Those who are over 80, and the AFib ends up being a bigger cause at that age for any type of stroke at that point. What I found was interesting, though, is that there's a study that looked at AFib and dementia and looked at those, especially those who were younger than 65 years old, were at an increased risk of dementia because of their AFib. It's a little counterintuitive, but the reason why is because if you're having these small changes, you have the AFib that's not treated, and you have small changes that happen over time and time. If you're younger than 65, you have many years to develop these changes. And by the time you're 80, now you're starting to have symptoms of dementia. Compared to someone who's already above 80 years old, they just have AFib for the first time, and they haven't had that time to have that change. And so it's really important that someone younger than 65 who has AFib actually gets it treated. That way you're not having these stroke changes happening over a number of years. So back to vascular dementia. You know what it is. It's bad blood flow to the brain over time that's caused by a series of strokes. What are the symptoms? Well, they vary depending on the region of the brain that we're in. So every part of your brain is special for a different function. So if we're talking about being in the frontal lobe, that's where your personality is. That's where your executive function, your decision-making. So if a stroke happens there, you're going to have probably a personality change. If it happens in your temporal lobe, that's right here in the side, that's your center for learning and memory. Right? That's classic memory issues or difficulty recalling facts or didn't know what you had for breakfast that morning, even though you just had breakfast. And then another example is the parietal lobe. That's kind of right here in the top. You may have loss of speech. That's aphasia, where you're trying to speak, but you're getting the wrong kind of words. So the symptoms in vascular dementia, they usually appear suddenly because strokes happen suddenly, and then you lose brain function with each stroke that happens over time. That's vascular dementia. So here's some common features of vascular dementia. It's usually, again, abrupt onset. This is someone who's probably doing pretty fine before this, but all of a sudden, the next day, things have just changed. Why? Because a stroke event happened in their brain. It's a stepwise decline. That means that you're doing well like this, and then all of a sudden, a stroke event happens, you kind of come down. Like you start coasting for the next year, you're doing okay, and you just come down. It's like a staircase. And so every stroke event usually puts someone down a little bit, and they kind of coast for a while. That's the stepwise decline. That's a little different than Alzheimer's. Yes, sir? Can you help a patient without having a stroke? Can you have what? He asked if you can have aphasia without having a stroke. Yes, you can. We'll get to it a little bit. We got questions at the end. You can. Gait disturbance, that's your walking. So walking is usually slower. So in vascular dementia, people tend to have slow processing where you can't walk. You have the strain, but you're just processing it very slowly. This is not Parkinson's, this is not anything else. You're just slowly processing your walk. Motor can be off, that means your movement can be off because of the stroke. You may lose function on one side or the other. Urinary incontinence, that's a big one. Now, as many of us age, I'm saying us, as many of our age, as many of us age, right? There's not a reason to have urinary issues, right? So if you got prostate issues, this or that, and so it may be a little difficult to tell, but in someone who didn't previously have a urinary issue, and then all of a sudden now it's like you're going on yourself, you can't hold it, stuff like that. That's a little different if you don't already have that issue. But now it's something brand new, I might look into it differently. So urinary incontinence is actually a really big symptom in vascular dementia. The last two are emotions and mood. Your emotions and mood can be very off. Now, if you're already kind of irritable all your life long, then just forget about it. Forget about it. We can't tell, right? But if you're someone who maybe didn't have this personality before, and now you find yourself a lot more moody, or your family's telling like, you kind of changed, that's another sort of symptom. And so there's a different constellation of symptoms that are not exactly like Alzheimer's tends to be. Okay, so how do you make a diagnosis? Well, really actually evidence of a clinical stroke, usually done by imaging or just like looking at you, and cognitive impairment in at least one major cognitive domain. So like the examples are your executive function, your language, your visual, spatial, video games are really cool for that. And then memory. Those are kind of the big cognitive domains. I kind of designed this, if you will. I call it the 456 A's of dementia, right? Yeah, see the picture of that? That's STILO right there. And I'm like number 7. The reason why is because if you go online, you might find the 4 A's of dementia. You may find the 5 A's of dementia. You may find the 6 A's of dementia. So I just put them all together, and I gave you actually lucky number 7. And so we'll take a look at this. The first one is aphasia. That's language. This is not slurred speech. This is specifically when you're trying to produce language. You want to say apple, but you say car, but you're just not able to produce as much words. You're trying to think of it. That's aphasia. Apraxia. This is difficulty with purposeful movement. So if I tell someone to lift up their arm, this is a person who has the strength to do it. They understand the command to do it. They want to do it, but they just don't do it. That's apraxia. Or if I tell you all to show me what it looks like to brush your teeth, most of us would probably take our hand and do this. You might use your finger and kind of do that's what it looks like. But someone who has apraxia might just look at their hand and just kind of, all right? So they know what to mean, but they just can't do that purposefully. That's apraxia. Anomia, that's when you have difficulty naming objects. Agnosia. This is where you have difficulty recognizing objects. So like you know it's a tree, but your chest, I don't know what that is. Just can't really figure it out. That's agnosia. Amnesia. We've heard that one before. There's a difficulty with your memory, remembering events, remembering facts, semantic stories. Apathy. This is when you just lose interest. You used to have interest in doing things, but you just don't have interest in doing nothing anymore. It's very not like yourself to be this way. And the lucky number 7 is a longer one. This one is called anosognosia. This is when you have lack of the insight into your condition. You can't even tell you're actually sick. You don't know how bad it is. You think you're doing fine, and you're clearly not, right? And so these are like I said, these are 7 in my world, the 7th, 8th dimension. Okay, so here's some pictures. This is an MRI brain scan of a 77-year-old person who's cognitively healthy. There's no memory issues, they're doing fine. If you can see a little bit of these little white changes that are there, that's called white matter changes, white matter disease. This is a little bit of damage over time. This person's 77. They've had a little something some years, but they're doing pretty fine. But I want to make a comparison and show you someone who has dementia, this 81-year-old. And you can see a difference in that white matter changes. There's a lot more in that person who has dementia than the other person who has vascular dementia. These are stroke-like changes that have happened in the person's brain over time. And here's another example of it. This is, as you can imagine, see there's a lot more white matter disease that's there. And so what's wild is that oftentimes I'll have a patient in the hospital for one reason or the other. We get an MRI of their brain. I open it up and I'm saying, you got a lot of disease there. And I say, have you ever had a stroke? I say, I've never had a stroke before. And I say, yes, you have. You've been having a lot of strokes for a long period of time. And this is when it's a little bit scary to think that you could have these changes to your brain, but you haven't had symptoms yet. But at some point, it's going to reach a critical mass where you finally have a symptom. And then we're like, oh, this is what's been going on this entire time. And so vascular dementia is a little bit like that as well. This is mostly driven by that uncontrolled, untreated, long-standing high blood pressure over time. And we don't always feel symptoms of high blood pressure. You don't feel symptoms of a random small blood vessel having damage here or there. Once it reaches the critical mass, that's when we have issues. And so I want to give you a little view. This is just different types of vascular dementia. There's nothing to memorize, but just to know. It's had many names over the years. They used to call it post-stroke dementia. You have a stroke, and something like that, you have dementia, kind of shortly afterwards. Then there's something subcortical. This is sort of that long-standing high blood pressure over time. You have slowness of walking, urinary incontinence, slowness of processing information. There's one called CADRC. That's actually a hereditary form of stroke. People have early life strokes, like in their 30s and 40s, headaches and migraines. There's amyloid. That's a different kind of protein that can build up in the brain that causes small microbleeds over time. It used to be called multi-infarct, multi-stroke dementia, or mixed dementia. So you can have vascular and then kind of combine that with a little bit of Alzheimer's, and now we have a mixed picture. So the point is, it's super complicated. And what they titled this is called vascular contributions in dementia. There's a lot of different vascular things that can happen that contribute to having dementia. This is another thing we want to show you. So this little small graph there pretty much is just saying this is the share of dementia due to one single cause. And so a person who is younger is much more likely to have dementia caused by one thing. But as we get older and older, the chances of it being just only one cause of dementia are a lot less. And now it's multifactorial. Now it's a lot of things happening. Blood pressure, it's the diabetes, it's the vascular, it's local genetics, it's kind of everything as you get older. And vascular dementia is, to me, the most important one because it has a lot of these preventable aspects, but also it impacts any other kind of disease that you do have. And so let's say that we don't know who's going to develop Alzheimer's while we're doing research. But if you had anything that was going to be like Alzheimer's, the vascular is going to make that worse, right? And so some folks may have a mild disease, but they didn't need to have the vascular on top of it because that's preventable. For testing, what do? We do what's called a mini mental status exam, it's an MNSE, or a MOCA. These are sort of screening forms that we do. I can give it to you here today, and you can do this. It's kind of an easy, a few minutes test that kind of screens you. But I recommend that people get a full neurocognitive evaluation. It's like a 3, 4, maybe even 5 hour long test. You draw pictures, you answer questions, you read sentences, just kind of do a full battery of testing to kind of figure out exactly what the issue might be. And what they're trying to test are all of your different cognitive domains, okay? Most of us recognize dementia as a memory problem, right? But some dementias are just a pure aphasia problem. It's just language. Or some are more visual spatial. So that full kind of battery of testing can really help figure out, number one, is it dementia? Maybe it's actually just depression. Depression can mimic dementia like you wouldn't believe it at all. And so this kind of testing can say, you know what, the pattern of your issues looks more like depression and less like actual dementia. And then beyond that, now we know which areas your issue is. Now we know how to focus what type of treatments for your specific type of issue and go from there. We go through labs as well to figure out if anything else going on contributing to it. And then lastly, I usually get a brain scan, MRI brain, to look at this, what might be causing it. So this is an example of that MNSE. It's a small little questionnaire. This is the MOCA. You'll answer questions. You might remember a few words given to you, identify some things in the picture. And this kind of looks like it's just a screening form. But beyond this, we're going to go and get that full evaluation. Right? So this is the MMSE. And I just want you to see it, right? So it's not something that was foreign if you have to take it one day, because there should be a person asking questions, write a few things down, and they kind of put the score together and say, you know what, there's some concern here. Let's give you a little bit more test. There's a good screening form. So I want to move toward this end of this talk really quickly, talk about risk factors. Now, I have listed this slide that I found that had 12 risk factors. Some of them are a little more, I think, obvious. We've been talking about them in general, like different health things. So I'm going to highlight a few that I think are kind of important. Physical inactivity. This is someone who's not in anything. It was wrong. I'm so glad that I saw videos of this event in the past. Many of you have been in the past. And so having physical activity is a good thing to happen, because not doing it is a big risk factor for dementia. Excessive alcohol consumption is a big risk factor. Number 6, infrequent social contact. So if you're isolating yourself from everybody, which no one here is, because y'all all here together in public, but if you're isolating yourself, not spending time with any single person at all, ever, that's a risk factor for dementia. Another one, number 7, is less education. But you may say, well, at this point, but you can always educate yourself in some kind of way. It's never too late to educate yourself. So less education is a risk factor. Another one here is number 11, is depression. Having depression, we're talking about untreated depression, is a risk factor of dementia. And interestingly, hearing impairment. And I also add in vision impairment. And so if you're having hearing loss and you're not working on getting it treated, that can hasten the possibility of having dementia. Look at it this way. We all have senses, right? We all learn our 5 senses: hearing, vision, taste, touch, stuff like that. So your brain needs that sense to stimulate the brain. If you're not hearing, then at some point the brain is like, well, I guess I'm going to take a little vacation because I'm not getting the signals I normally get. So if you try to, at least work on the hearing loss, hearing aid, get some Apple AirPods, get something, then you may kind of help stave that off. The same goes with vision. Yeah, vision issues. Eventually that sense that you normally get starts kind of going away, and your brain is now not stimulated. So hearing loss and vision loss are actually risk factors for dementia. I think it's very interesting. And so the question is, can you prevent vascular dementia? What do you say? And the answer is yes. The answer is actually yes. There's an old adage that's called diagnose and adios. This is a picture of the tools that I use every day as a neurologist. Any of you been to a neurologist before, you know that many of us carry a big old purse full of tools, hitting you with hammers or shine light in your face, kicking you, making you walk, exercise, stuff like this. And for many years, 50 to 100 years, neurologists are fantastic. They have been fantastic at just looking at you, doing the exam, and knowing exactly what's wrong. They just great like that. But the problem was, many years ago, they used to call it diagnose adios. It's like, I know exactly what's wrong with you, but I ain't got no treatment. Well, then what's the point, right? Well, we had to get to this point. And so the reason why I say it is because in my very short career so far, last 10 years, the amount of treatments in neurology across the board have drastically changed, especially in my role with stroke. But even the last 5 years, things that we can do now are different than we did 10 years ago. My grandmother died from complications of stroke. If this were 2012, she might have walked out of the hospital about 2 days later. Like, no exaggeration whatsoever. And so, used to be called diagnosis and adios. So this is kind of why I like to talk about stroke, talk about these issues and kind of get there, because now we have treatments. And so it's no longer just, I know what your problem is. Now it's like, I know what your problem is. We can actually do something about it. And so, how many of these can be fixed? These are the same 12 risk factors we talked about a minute ago. Easy things to change. Less education. You can change that. Social isolation, physical inactivity, air pollution, that's one as well. Smoking, alcohol, hearing loss, and obesity. All right, we're still counting things that we can actually change. Going on to high blood pressure, you may need some more professional support. But high blood pressure, there's traumatic brain injury. If you got hit in your head, with that as a kid, we can't change that one. If you got diabetes or depression. So we're talking about, from this list alone, 11 out of the 12 things are things that you can modify, that we can modify, not just modify, but fix and cure to lower your risk for dementia. So it's really positive in my world. A couple of few nuts and bolts, cholesterol numbers that our people want to know. Total cholesterol, we always want it to be less than 200. As I mentioned before, the breakdown is important. So that LDL, that's the bad cholesterol. Most doctors say let's go less than 100. But then someone who has had a stroke or who might be at risk for a stroke, we want it to be less than 70. The HDL, that's the good cholesterol. So we want that to actually be high. So if it's less than 40, you still have a little risk factor for heart disease. So we want it to be higher than 60. Okay? How should you eat? Well, we can talk all day about that, but I want you to avoid the saturated and trans fats, because those are the ones that increase that LDL. And there's a whole list of foods here, but the omega-3s, the omega-6s, those are the parts of fats that fight that bad cholesterol. The problem is our bodies don't naturally make enough of it, and so we have to get it in our diet. That's where that oily fish, the nuts, the seeds comes in. There's a bunch of food we can talk about later that add to that. The last part is the DASH diet. We've heard this before. It's been around for a long time, but it's still rated as one of the best diets that's there. It's dietary approaches to stopping hypertension. So DASH diet, so I put Miss Dash right there. Salt-free. I know there was some flavor in our food, so we try to make it bland, right? But you kind of reduce the salt. But the DASH diet, if you sum it up into a couple of statements, is really just reducing fats, reducing red meats, and reducing the sugar in your diet. You make that a lifestyle, combining with exercise, you're on your way to good health. A glass of wine per night is not actually a good idea. It's been debated for a long time. I'm just gonna put that to rest. I'm gonna put it to rest. I'm not. And if you want to fight me, you can fight me on this one. But a glass of wine per night is not. People say, oh, it's a good thing for your heart. Yeah, there's some debates about that. It really, if it's true, they tested wine. It was really the red stuff in wine. It wasn't the wine. It was the red stuff. It wasn't the alcohol. But anyway, if you don't drink, there's no good reason or medical evidence to say you should start drinking to help your heart. Okay. Alcohol increases your risk of high blood pressure and atrial fibrillation. But if you do drink, then I would just say focus on cutting back a bit. Right? You can reduce your heart disease risk, you get better sleep, improve concentration and memory, you can lower your anxiety and your depression by cutting back on alcohol. Last thing is to improve I want to help improving your support memory if you have stroke. And so a couple of thoughts is memorize, visualize, associate. So I ask people to chunk information together, so cluster it. So instead of learning 4, 0, 9, 6, 7, it's easier to just group it. Right? It's 40, 96, 7. It's something very simple, but it's powerful to just kind of group it together. Visualize. That means I want you to imagine yourself doing and completing a task. So if you got to get out your house and go walk down the street, think about it first. Close your eyes. Imagine doing all the steps it takes to get from A to B, C to E, Think about it and think about it in reverse. It'll help you actually complete that task when you actually need to do it. Associate. I want you to join information together. So if you want to remember the information from the doctor's visit, then you get that piece of information and associate that with the stethoscope or the hammer you got hit with by a neurologist, right? The more personal you make that association, the more likely you're going to be able to remember that factual information. The last part of it is actually cognitive rehab. If you have that big neuropsych testing, that all those domains, figured out exactly which part is your difficulty, then rehab is aimed at that specific thing. I want you to share the struggle. Some of you are worried, right, about sharing that you have memory issues, but you won't tell anybody, especially men where you used to be the protector, but you're not protecting anyone by not sharing. And you're likely going to extend your own life, your own health, your own quality of life by sharing what's going on. It's more stress to hold it in. We've heard the time that it takes a village to raise a child, right? Well, as Nas said in the album, once a man, twice a child. And so if it took a village to raise me, it's going to take a village to keep me, right? And so you need that support, you need that love. This is my call to action. I want you to get intimate with your risk factors. Like, it's about knowing them inside and out. When someone asks you LDL, you're like, I know what it is. You ain't got to be that. I know my risk factors, right? And so knowing them intimately and then share that with at least one person as your accountability buddy. Just to make sure you're having that communication, you're having that kind of conversation going with someone else. Get tested as appropriate. If you haven't done any of this, I know it's not anyone in this room, but start at the beginning. I got to check my diabetes, I got to check my blood pressure, I got to check my weight, I got to check my BMI. You got to start from the beginning, get tested as appropriate. Don't be anxious, enjoy your life. And I want you to share your story, as my grandfather did. Because despite any threat of dementia, you will live on through the stories that you share, how you impact those around you. And so I just say your memories are only lost when you don't share them. Okay? That's what I feel today. Thank you.
So, I know what y'all are thinking. Let me just dispel some of them. Let me put y'all at ease. He started in college when he was 14. That's why it looks like he's 20 now. The other thing is that this is the other thing y'all think. He's not the damn AI robot doc. He's just that damn smart. So give him a hand, Dr. Rolle. We sort of would is the one. One of the things that I'm really curious about is mini strokes. Those ones that the strokes that we don't know are occurring. And are there any ways to detect those or know that that's something that could be happening to us, maybe during the sleep periods or something?
It's a very good question. The true answer is no. Not gonna lie. As good as neurologists might be, we also at this point rely upon imaging. We didn't notice 100 years ago. How do we have imaging? We just find things out that we're like, oh, now we know that's been happening. And so if you haven't had any symptoms, or you haven't changed a single bit, you're not gonna know. But it's not common to open up an MRI scan and see that stuff in someone whose risk factors are controlled. If your blood pressure has been great, diabetes is great, cholesterol is great, it would be really odd to open up your brain scan and see all that stuff in it. And so even though we don't know that it might be happening unless you get that scan or a reason to get the scan, having a knowledge of your risk factors and where that is, when you do that. I had a guy one time answer your question as well, that his risk factors were pretty okay. He did well, but he had a history from about 20, 30 years ago where he had a period of time he wouldn't take care of himself for a very long time. And that's what explained it. He had spent time, he was at the height of the crack epidemic, and so he's like, yeah, I was doing this, I was doing that. So he had a good 14, 15 years he couldn't really account for. So that may have done it in that particular person. It doesn't mean that damage is going to keep on happening just because it's there. That damage is done, but at this point, you can still then go prevent more damage from occurring.
Excellent. So we're going to start the Q&A out. I've got Eric. Eric, where are you? Raise your hand. Eric is over here. Eric is new. Welcome him, by the way. Join the staff. Next wanting to pass the microphone around on this side of the room, and I'm going to go on this side of the room. And again, just for those who may not have participated in our Q&A before, please address your question as a question versus statement as our commentary. We're going to make sure that we get the most information out of the doctor while he's in the house, okay? So maybe if you have some commentary, you can share that with him. Maybe say something. Is that okay? Yeah. Okay. All right. We're going to start on this side. We got one right here. Let me just get him right since he's so close.
Thank you, doctor. I recently had an interaction with a neurologist talking about cholesterol, and that the brain needs cholesterol to help counteract the conditions of dementia. So I said, well, that's counterintuitive because I'm told that I got to keep my cholesterol low, and you tell me I need cholesterol for my brain. So how do we reconcile these issues?
What I would say with that is cholesterol is just one word. We got to remember that it's broken down into multiple aspects of what cholesterol is. It's true. The brain thrives on a lot of fats, which is based on cholesterol. But the LDL is sort of like it grabs cholesterol. It's like a dump truck, and it sort of dumps it off different parts of the body. The HDL is what actually grabs it and takes it and removes it from those vessels. And so that LDL is what puts the plaque in the vessels. The cholesterol that he's talking about, or she may be talking about, that your body needs, that's in the actual cells of your body, your actual brain cells. It's not inside the blood vessels. So we don't need all that fat cholesterol to line the blood vessels. We need the blood to transport it from one space to the other without just leaving the trash behind, so to speak. So the LDL is transporting it. And if it does leave anything behind, the HDL, the good cholesterol, is what actually picks up and cleans it and takes it away. And so, we all need components. We need salt to live, but too much salt's a problem. So I think that's kind of the breakdown that's important. So if you look at your cholesterol numbers, total cholesterol is important, but the ratio of that LDL to HDL is important. That's what we look at.
Excellent.
Just a quick question. You said something about, which you were talking about, the full neurological test. When would you recommend everybody have that if you had some bouts of depression? Or is that something that is so individual you can't really say? I mean, you said there's that versus it could be disguised as depression.
What I would do is I would probably start with one or both of the screening forms. So remember, it's the MMSE. The other one's called the MOCA. That's a screening form. If you do that screening form and you basically pass the flying colors, you're probably going to go to a full site testing and probably do pretty similarly. And so I would probably say start with the screening form. But even beyond that, there is concern that, there's some depression, or I've had a little bit of changes. Maybe I'm forgetting things more frequently than I used to. I don't know if it's just normal, what they call normal aging. Then I would definitely get the testing for sure. That's done by a neuropsychologist. Those are the persons who does that neurocognitive evaluation. We do them upstairs here at the Brain Health Center, but you're looking for a neuropsychologist that does that test. Yeah.
Got one right here, Eric. Eric, would you? Yeah. Oh, he doesn't.
Well, thank you, Dr. Rolle. Great presentation. Question, would you suggest any baseline diagnostic testing labs, someone who just had like a general concern about issues such as vascular dementia? What would you suggest would be the entry point, if you would, in your conversations with your own PCP or healthcare practitioner?
And you're asked about any baseline testing?
If baseline testing, labs, any things of that nature, you're having a conversation with PCP and you're just trying to start that process.
Sure.
What would you recommend?
So I would say there's a couple of different categories. Number one, there's a category of person who is already on several medications for different reasons. I'm a big fan of looking through someone's medication list and being like, why are you on all this stuff? Now, sometimes you need them all, but sometimes you don't. And a lot of things get started for one reason, but then no one knows why they're still there. And every doctor is afraid to stop them because some other doctor started them before. And that's reasonable. And so sometimes you may have issues because of the multiple medications that you're currently on that should be looked at. That's one aspect. But beyond that, it would be the specific labs that we do. Honestly, there are just two of them. One is a vitamin B12. B12 is just a vitamin that is really, really important for our nerve or neuron or brain function. And so a lot of folks who have low B12, they tend to have a range of symptoms. A range of symptoms coming from neuropathy, like nerve pain, nerve damage stuff, all the way to brain fog and just kind of like not feeling yourself. And I'm not gonna lie how many times I have had someone in front of me with random symptoms and we checked their B12, it's really low. And low for neurologists is not low for PCP. We want it to be like above 500. And so not going to be low for, but I will give them B12. You know, we actually do like a intramuscular injection, so I bring it up quickly. So I treat you at home with supplements, and people end up doing a lot better. So B12, I would check B12, and I would check your thyroid function. That's the TSH. So your thyroid is a hormone that affects a lot of parts of your body, and the thyroid can mimic a lot of different types of other diseases when it's abnormal. And so the B12 and the thyroid, of course, we talked a little bit about cholesterol, so that's going to be in there as well. The A1C is what we use to see if you have diabetes or not, or what level it is. Those are the labs that I would check. And then finally, from a family doctor standpoint, PCP, the carotid ultrasound, many people are usually referred to get that at a certain age and or risk factors. And so carotid ultrasound, these are the two biggest blood vessels that are in your neck that feed your brain system. And so we can tell based on that, wait a second, you've actually got some decent amount of buildup. Let's start targeting this more specifically. That's what I would start with.
Excellent. We've got one here, and then I think we've got one more over here.
Thank you, doctor. Quick question. I've been on like globoside 40 milligrams for quite a long time, and I was wondering, should I ever get off of the cholesterol?
What's your cholesterol?
It's pretty low.
What is it?
Get intimate. Get intimate with it. I'm thinking about my diabetes, like 199. It's about around. Diabetes is about 167, but top of my head from cholesterol, we can remember those.
Yeah, I mean, you know, I'll get this disclaimer right. I know you got to talk to your own doctors. Make changes to your medications right here. I'm not going to step into that role, but I'd say with that, the cholesterol medications, we have two different versions of them. Some are called high intensity. That's pretty much some of those cholesterol is through the roof, and we're trying to get it down quickly. And we have low intensity. So if you're already cholesterol is really good, then at the very most, you should get a low intensity version of that. Now, do you need to be on medication forever? The answer is no. But that really depends on whether or not you're doing anything of your own power to keep it low.
Does the PBC have anything to do with that? Premature?
It does not. No, it doesn't. So yeah, so I think when you want to get off medication, which I totally support, you got to make sure you're also adding to your own lifestyle something that keeps it down. You know, so you're not dependent on the medication. If you're like, oh, woof, I got there, medication's off, well then now all of a sudden you're back where you were before. So you got to kind of add to it, and you take over yourself, and now it shows you on your own body.
And I knew that we were going to have a lot of questions about Rolle. This is really, really rich content. And I tell you what, he's got a lot of knowledge, but I know we're not going to be able to get to all of your questions, but we've got time for maybe 3 or 4 more. So, Eric, can you work that side over there with the red sweater vest on? And then I've got, this gentleman right here next. Henry.
All right, doctor, what do you think the range should be for high blood pressure? When is high blood pressure high?
Your blood pressure should be less than 130 on the top number and 80 on the bottom number.
What is considered for long-term? I mean, months or years or.
You mean like, but say your question again?
What do you consider, you said long-term? What is long-term?
Meaning that if your blood pressure has been higher than those numbers, over a period of months to years, that's like long-standing, uncontrolled high blood pressure. Yeah.
Excellent. We got one right here, and then we're going to go back on that side. Okay, give me just a minute. This gentleman had his hand up first.
Thanks, Dr. Rolle. I want to know what a distant infarction in the cerebellum means.
Distant?
Yes.
Is it distant or distal?
Distal.
Distal. Okay. So it means a stroke.
Okay.
The cerebellum is in the back part of your brain, and that's mostly your center for balance and coordination. And so that would indicate that someone's had a stroke in that area that's important for balance and coordination. How large or small is it? I don't know, but that's a stroke. When it's functional, what is the distal means far away? So we talked about the tree trunk, the very bottom. The further you go out, that's more and more distal away. So it's probably in a smaller blood vessel, not one of the largest ones that starts the whole tree off.
Thank you, sir. You mentioned about hearing being an important part, and you also mentioned the Apple iPods. So how does that work?
I mean, I said that to say that hearing aids are the best. But, there are some folks who, they just ain't there yet. They don't want to go there. And full disclosure, I had been 2 years ago diagnosed with hearing loss myself, both ears. Told me I'm going to eventually need hearing loss, okay, at my old young age right here. But I said it to say that our government in the last 1 or 2 years changed laws surrounding hearing aids, and they allowed more companies to be able to compete and also make products. It used to be that it was just two or three companies that made all hearing aids, but now everybody can get in there. So now there's a bunch of Bose and Apple and this company, that company, they're making headphones. They're headphones plus hearing aid. They look cool. They got Bluetooth. They do all kind of fun things. So that's if you don't go the full hearing aid route, you can maybe at least start with one of those kind of hearing devices that are just a headphone, and it can tune to your hearing issues and see how that does for you. You might like that and say, "Whoa, I'm hearing a bird's chirp now. Let me go in and get the hearing aid."
Yeah, I might need to do that myself. I apologize. I heard Derek instead of Eric, and I heard Eric instead of Derek. So his name is actually Derek. So just apology. We've got time for one more on this side. One more on that side.
Thank you, Dr. Rolle. How concerned should a person be about the mitral valve defect? Is that any way related to atrial fibrillation?
Not directly. It's probably a better question for a heart doctor, but not directly. Any of these valve issues you have, they can be mild to all the way really severe. And so I can't say it's not related at all. But mitral valves in a different area than the area that you create that AFib from. So it's not usually related at all. Not usually.
Austin, you get the mic and stand up, please, so your voice will project better.
Good morning. Thank you for coming in here. I've been hearing a lot about a different type of cholesterol. I don't know if it's the LP-A. What is that? And how's that affect cholesterol?
So just as you all are here hearing about research, LPA is called lipoprotein A. It's just another one of these components that they found in the last 5 or 6 years also drives possible high cholesterol numbers. It also may predict possible worsened heart disease. And so it's called lipoprotein A. Whenever someone's in the hospital, I suspect that they may have a lot more cholesterol buildup than I might expect for their age or for their risk factors. I might also add a lipoprotein A to their lab set because that may be a possibly different genetic factor that is also contributing to why they have so much high cholesterol. So once in a while, you come across someone who is fairly healthy and they've got a lot of buildup in their blood vessels. of cholesterol. Two reasons. One could be that lipoprotein A is kind of high. The other one is, we didn't talk about this earlier, but for anyone who has ever needed to have radiation, for any reason, especially if you have radiation to your head, your neck region, and radiation accelerates the development of that plaque, which is not anything to do with the cholesterol level that you have. And so that is a completely different conversation. That's an independent risk factor that if you've had radiation, it's possible that you're actually developing more of that plaque for reasons that are not the typical reason that we have. So that should be monitored and treated the same way, but that's a reason why you may have plaque that someone else doesn't.
Is that permanent?
The changes that happen are not necessarily permanent, no. And it can be prevented from forming more and prevented from sort of, as we talk about, the plaque can be unstable, which means that it can actually flick off a small piece and go into the brain. We can stabilize that plaque by the diet and by the medicines. But what's there is there. It isn't just all away.
Thank you so much, Dr. Rolle. This has been an excellent presentation. We truly appreciate this young man here. Yes. You will get into yes. I want to thank not only Dr. Rolle for coming in and doing this for us, but we also want to thank the diligent Emory staff, Dr. Monica Parker, for always seeking these very talented and smart individuals to come over here and talk to us and share information about our health. So yeah, give the Emory staff a big hand for getting this